Welcome back to OMFS Essentials. This episode concludes our detailed sequence on impacted third molar surgery. Having completed the procedure, we now focus on the critical steps that ensure a smooth recovery, meticulous post-operative care, timely follow-up, and the management of both expected and potential complications. 1. Post-operative care and edema control. The primary goal of immediate postoperative care is controlling bleeding and minimizing inflammatory edema. A. Hemostasis. A pressure cac must be maintained for about an hour post-surgery to achieve adequate hemostasis. B. Edema management. Edema is characterized by vasodilation and increased capillary permeability. Excessive edema causes tissue tension, which can lead to suture dehiscence and retarded healing. 1. Immediate phase, first 24 hours. Apply intermittent cold compression. Cold induces vasoconstriction, which reduces blood flow and prevents excessive formation of inflammatory exudates. Later phase, after 24 hours. Introduce warm saline gargles, a hypertonic solution. The warmth induces vasodilation, improving local circulation, reducing stasis, and facilitating reabsorption of interstitial fluid. The hypertonicity of the saline also helps draw fluid out of the tissue. Glycerin magnesium sulfate dressings. Applying this dressing extraorally is highly effective. Magnesium sulfate is hygroscopic, drawing fluid across the skin, which acts like a semi-permeable membrane. The reaction is also exothermic, working like a hot fomentation to induce vasodilation and improve circulation. Medication. Prescribe anti-inflammatory drugs and analgesics. However, sound surgical technique, that is, tissue respect, less bone trauma, and loose sutures, is the best prevention. The edema typically increases up to 48 to 72 hours before gradually receding. Wound hygiene. Maintain oral hygiene using antiseptic gargles, such as chlorhexidine or povidone iodine. 2. Follow-up and neurological assessment. The first follow-up visit, preferably on the subsequent day, is vital. Clinical check. Assess edema, pain, trismus, and wound condition. Neurological evaluation. This is critical and is performed on the first postoperative day after the effect of the local anesthesia has completely waned. Assessment is done by checking the perception of fine touch, prick, and two-point discrimination. Lingual nerve. The taste sensation on the tongue must also be ascertained, as taste fibers are relayed in the lingual nerve via the chorda tympani. Rationale: early detection and explanation of any neurological deficit to the patient is crucial for establishing prognosis and management. The taste sensation, once damaged, is very seldom restored. 3. Alternative surgical techniques. A. Lingual split technique by William Kelsey Fry. Principle: this technique exploits the thinness of the lingual cortical plate. The lingual bone is intentionally and carefully removed, and the tooth is delivered lingually. Risk: this is a technique that is difficult to master and is associated with a higher chance of lingual nerve damage if the lingual soft tissue is not adequately guarded or if the dissection plane is incorrect. B. Coronation. Principle: the crown of the impacted tooth is removed and the roots are intentionally left behind. Indication: primarily used for deep position C impactions where the roots are in close proximity to the inferior alveolar nerve. Rationale: this is done to prevent IAN damage. As the tooth becomes non-functional, the roots often undergo resorption and become more superficial due to alveolar bone remodeling, making their eventual removal easier and safer. Complications: the main risks are late infection or the development of pathology associated with the retained root fragments. 4. Complications of third molar surgery. While many complications are transient, some can be permanent or severe. Edema. Excessive edema is usually caused by excessive tissue handling, tight suturing, or secondary infection. It should resolve quickly, but if not, one suture may be removed to decompress-drain the exudate. Trismus, or jaw stiffness, usually temporary secondary to protective muscle spasm and pain. Persistent or severe trismus may be due to injury to the temporalis tendon or medial pterygoid muscle during the nerve block, or TMJ strain or arthritis due to prolonged surgery or lack of support during elevation. Requires anti-inflammatory drugs and physiotherapy, short-wave diathermy, jaw exercises. Infection. Can be an exacerbation of previous pericoronitis or a new postoperative infection. Since anatomical barriers are broken during surgery, infection can rapidly spread to deep fascial spaces. Decompression, removing a suture, may be necessary to drain pus. Nerve damage. Damage to the lingual nerve or inferior alveolar nerve due to sharp instruments, burr slipping, or a fracture of the lingual plate. Fractures. Fracture of the alveolar bone, especially the lingual cortical plate. Jaw fracture. Due to injurious, excessive force applied with heavy elevators or too much bone removal, weakening the angle. Hemorrhage. Due to damage to the facial artery or inferior alveolar artery. Dry socket. Its remaining is a separate, well-known complication. Displacement. Tooth or root dislodgement into the sublingual space. The final success of third molar surgery is measured not just by the tooth's removal, but by the avoidance of permanent complications and the effective management of the body's inflammatory response. You've been listening to OMFS Essentials. This concludes our in-depth series on impacted third molar surgery. As always, keep mastering the essentials.